Welcome to the deep dive. Today, we're cracking open some notes, really trying to make sense of pediatric revision material, make it high yield. And the topic today is one you'll definitely see, something parents often worry about quite a lot: childhood constipation.
That's right. And our aim here really is to take all this key information and just distill it down, give you the core facts, the important distinctions, definitely the red flags, and, the management side too, in a way that hopefully sticks for your revision.
Yeah, exactly.
We're covering the definition, causes, how it presents, investigations, management, the whole picture, really, right through to long-term stuff.
Consider this your shortcut, sort of to getting your head around this really common issue. We're pulling out the key bits, maybe adding a few memory aids along the way. So let's just jump right in. When we talk about childhood constipation, what does that actually mean? Sounds straightforward, but getting the definition clear is step one.
Well, at its heart, it's about infrequent bowel movements and difficulty passing them. So typically that means stools that are hard, often dry, maybe painful, and it disrupts their normal bowel habit.
And it's really common, isn't it? The figures are pretty stark, affecting, what, 5 to 30% of kids? It's a huge reason for pediatric referral.
Absolutely, 3–5% overall, but yeah, up to 25% in gastro clinics. Parents notice the infrequency, the pain, sometimes these massive stools. And the tough part is maybe a third, even more, end up with chronic symptoms.
Wow.
And this is really critical, something the notes hammer home.
Yeah.
You must assess and diagnose properly before reaching for the laxatives. That's the golden rule. Diagnose first.
Makes perfect sense. You could miss something serious otherwise. So, okay, how do we define it properly? You mentioned the Rome 4 criteria.
Yes, they provide a really useful framework, especially for the little ones, infants up to 4 years old. Rome 4 helps define functional constipation. You're looking for criteria like fewer than 2 bowel movements per week, or a history suggesting stool retention, holding it in, painful or hard stools, sometimes finding large diameter stools, or feeling that fecal mass in the rectum.
And there's an extra bit for kids who are already toilet trained.
Exactly. For them, in addition to those other signs, having at least 1 episode of fecal incontinence per week is another key criterion. That soiling, it's often linked to the constipation itself.
Right, the overflow. And then there's chronic constipation. That's if it's been going on for, what, 8 weeks?
Yeah, 8 weeks or more. And the criteria there typically include fewer than 3 bowel movements a week, plus, again, 1 or more episodes of fecal incontinence per week.
Okay.
Other things, too. Feeling that stool mass in the abdomen or rectum, passing those really large stools that can block the toilet, those withholding behaviors like arching their back, going on
I
tiptoe.
see them doing that little dance.
Exactly, that posture. And, of course, painful defecation itself.
The source notes also clarify a few related terms, which is helpful.
Yes, definitely. Fecal incontinence, it can have organic causes, but usually in this context, it's functional. It's that constipation-associated overflow soiling. Less often, in older kids, you might see non-retentive incontinence, where they soil without holding on, and that's different, needs investigating.
Right.
Then fecal impaction, that's the big, hard mass that just can't pass. And pelvic floor dyssynergia, that's a coordination issue, where the pelvic floor muscles don't relax properly when they try to go.
So these definitions really structure how we think about it and diagnose it. Okay, moving on. Why does this happen? The notes say it's often multifactorial.
Right. It's rarely just one thing. For the common functional causes, it's often the stuff you'd expect. Not enough fiber in the diet, not drinking enough fluids, maybe not enough physical activity, emotional factors too, stress, anxiety, changes.
Like starting school.
Yeah, exactly. And some medications can play a role too.
Okay, but here's the crucial bit for revision, isn't it? Knowing when it's not just functional, what are the main organic causes we need to have on our radar, and what are the clues?
This is absolutely vital. Missing an organic cause can be serious. So thinking in categories helps.
Okay.
Anatomical. Things like anorectal malformations,
Get
key
that.
action. Always check the anus position visually. Maybe a DRE if you're worried.
Okay.
Structural or local.
Right.
Anal fissure, look for pain. Bright red blood, maybe the little skin tag, the sentinel pile. Rectal prolapse, maybe from straining, but could be nerve issues or even chronic diarrhea.
Okay.
Neurological or gut motility. Hirschsprung's is the big one here. Presence early, fails meconium passage, doesn't respond well to laxatives. Diagnosis is rectal biopsy. Why? The notes specifically mention barium enema is suggestive, but not anorectal manometry for diagnosis in this situation.
Yeah. Biopsy for Hirschsprungs.
Yeah. Also, neuroenteric problems affecting motility, again, needing biopsy.
Spinal cord issues.
Look for those sequel signs, dimples, hair tufts, maybe lower limb or bladder problems. Needs a good exam, MRI, and anorectal manometry for function.
Makes sense.
Muscle coordination, pelvic floor dyssynergia, that coordination problem.
Yeah.
Diagnosed with anorectal manometry.
Yep.
Systemic or metabolic. Think hypothyroidism, check TFTs. Coeliac disease, check coeliac tests. Hypocalcemia, check calcium. Cystic fibrosis, do a sweat test. These affect the whole body. Toxic, check lead levels if relevant. Allergy. Sometimes cow's milk allergy presents this way. You might try an elimination diet or allergy testing.
That's a really helpful breakdown. So functional is mostly history and exam, but these organic ones need specific tests.
Pretty much. Functional constipation, history, and physical are your mainstays. Rarely need more. But, and this is stressed again, non-retentive fecal incontinence, that soiling without withholding always warrants investigation. Think radiology, maybe colonic transit studies.
Okay, good distinction. Now, what about risk factors? What makes a child more prone to this?
The material lists a few key things. Family history definitely pops up. Poor diet, low fiber, obviously. Dehydration, a sedentary lifestyle, not moving enough. Issues around toilet training could be a trigger. Psychological stress, big life events. And of course, certain underlying medical conditions or medications can increase the risk.
So these are all flags to look for in the history, potential contributing factors for that particular child. Okay, so we know why it might happen, but what's the actual process? The pathophysiology, what's going on in the gut?
Well, the core mechanism described is basically things slowing down. You get delayed stool transit through the colon.
Right.
So the stool sits there longer, and the colon does its job of absorbing water. Maybe too well. So more water gets absorbed, making the stool harder and drier.
Ah, okay.
And this slowdown and drying out can stem from things like decreased colonic motility itself, or insufficient fiber to bulk things up, or those defecation issues like the pelvic floor not relaxing properly.
So it's a combination of slow movement and excessive drying. Makes sense why it gets difficult to pass. Okay, differential diagnosis. If a child comes in looking constipated, what else should be on our list? Crucial for a revision list.
Absolutely. You need to consider other possibilities. The main ones highlighted are functional constipation, obviously the most common, related to habits, diet, withholding. Hirschsprung's disease, remember absent nerve cells, early onset, biopsy. Hypothyroidism, slows everything down. Anal fissures, painful tears, often a result of constipation, but can make it worse.
Vicious cycle.
Exactly. Intestinal obstruction, a physical blockage. More acute, usually vomiting, distension, not passing stool or gas. That's an emergency. Medication side effects. Think opioids, some antihistamines, iron supplements.
Right. So you're always keeping these in mind, especially the serious ones like Hirschsprung's or obstruction, and looking for clues that point away from simple functional constipation. Let's quickly revisit the numbers. Just how common is functional constipation specifically?
Well, as we said, overall prevalence is 5–30%. But the really striking figure is that functional constipation makes up over 95% of all childhood constipation cases globally. The pooled rate is about 9.5%.
Oh,
95%. Yeah. It affects boys and girls roughly equally overall, although functional type might be slightly more common in girls. Peak times are preschool years, and those transitions, toilet training, starting school. The median age it starts is around 2.3 years.
And most kids are developmentally normal, right? But it can be linked with things like tricky toilet training, psychological stuff, stress, neurodevelopmental disorders.
That's right. There can be associations, definitely.
Okay, so how does it actually look, the clinical presentation? What do parents tell you? What do you see?
This is where the history is king. Parents will report infrequent poops, hard or dry stools, straining. Kids might complain of tummy pain or discomfort, bloating. That stool withholding behavior is a big clue: hiding, crossing legs, stiffening up, trying not to go, sometimes decreased appetite too. And you need to ask those really specific questions. How often? What's the consistency? Use the Bristol chart. Ask about rabbit droppings. Any soiling or incontinence? How often? What's it like? Does it hurt to poop with the stools? Block the toilet? Any changes in behavior around toileting? That pain withholding cycle is so common, especially in toddlers.
Absolutely. And the examination, what are the key things to look for or not look for?
On exam, definitely palpate the abdomen feel for that fecal mass. Carefully inspect the perianal area. Look for fissures, redness. Check the anus position is normal. Check the lower back for any sacral abnormalities. But here's a really key point from the notes, vital for revision. Rectal examination is not routinely needed or required.
Okay, that's important.
And similarly, routine abdominal x-rays are also not recommended for diagnosis. History and visual inspection are usually enough for functional constipation.
Big take-home points there. History is paramount, invasive exams and routine x-rays are generally out unless there are specific red flags. So giving that, what investigations do we actually do if history and exam are primary?
Exactly. The notes are very clear. Diagnosis primarily relies on clinical history and physical examination.
Okay.
The diagnosis is essentially confirmed by finding those specific features we talked about. For under ones, less than 3 stools a week, unless breastfed, large hard stools, distress bleeding straining, history of constipation or fissures. For older kids, those things, pleolas overflow soiling, massive toilet blocking stools, appetite improving after pooping, tummy pain relieved by pooping, that retentive posturing, pain straining.
So finding those is the diagnosis in most cases. When you think about extra tests then, bloods, imaging.
Only if you suspect an underlying organic cause or complications. Abdominal x-rays or blood tests are mentioned as examples of things you might consider if there are red flags, but definitely not routine just for constipation itself. Don't order them without a specific reason.
Got it. Right, let's move on to the management. This is the big one. How do we help these kids? What's the approach?
Okay, management goals first. The notes lay them out clearly. 1. Clear out any fecal impaction. 2. Get them back to a regular bowel habit. 3. Encourage self-toileting if they're old enough. 4. And promote using the toilet appropriately.
Makes sense. So step 1, clearing the blockage.
Yep, that's disimpaction. You need to clear the backlog. The recommendation is to start with osmotic laxatives like PEG, polyethylene glycol.
Yeah.
You gradually increase the dose until things start moving well. Stimulant laxatives might be added temporarily if needed, but osmotic is first line here. You review them weekly during this phase.
Okay, so clear the decks first, then what?
Then comes maintenance therapy. And this is the crucial long-term part. It involves several things together. 1. Dietary advice. Bump up the fluid and fiber. More fruits, veg, whole grains, water. 2. Monitoring. Use a bowel diary or chart. Really helps track frequency, consistency, soiling. Great for parents and for you. 3. Laxatives. This is key. They need regular maintenance laxatives, usually osmotic ones like PEG, often for months or even years. The notes really stress avoiding stop-start treatment that just leads to relapse. Stimulant laxatives. Use them only intermittently if needed to prevent reimpaction, not for daily long-term use.
Months or years, that's a big commitment. It's not just a quick fix. What about the behavioral side, the withholding?
Behavioral modification is essential. Encourage regular relaxed toilet sits, maybe 5–10 minutes after meals to catch that natural urge. Use positive reinforcement, reward systems. Start charts for sitting on the toilet, maybe eventually for doing a poop. Linking the diary to the rewards can work well.
And the incontinence, the soiling, that must be distressing.
Hugely. First step is explaining to the child and parents that it's involuntary overflow, not their fault. Continue with the regular toileting schedule. The school nurse can be a brilliant help here, offering support and ensuring privacy at school.
When do things get serious enough to refer to a specialist?
The notes list clear indications. Suspected organic cause or red flags, obviously. No improvement after, say, 3 months of good management in an older child, if it's just really complex. Or, unfortunately, if there are safeguarding concerns, suspected child abuse. And if they do see a specialist, what might happen then?
They'll likely investigate further if needed, maybe check inflammatory markers, thyroid function, coeliac screen. Sometimes they might measure colonic transit time.
And surgery. Is that ever needed?
It's rare for functional constipation, reserved for really severe, stubborn cases. Things like botulinum toxin injections are sometimes used for very specific issues, like short-segment Hirschsprungs, or to temporarily relax the sphincter, but it's not common. The evidence for purely psychological interventions is limited unless there's a clear underlying issue. The mainstay remains laxatives, continued long-term, withdrawn very gradually once things are stable. Enemas are usually specialist territory used before considering surgery, which, again, is uncommon.
Okay. What about the long term? What's the prognosis? It's variable, the notes say. For functional constipation, the outcome isn't always straightforward.
Are there factors that make it more likely to stick around?
Yeah, things like onset really early in infancy and a family history of constipation seem to correlate with persistence. But the good news is, prompt identification and treatment definitely improve outcomes. Delaying treatment for more than 3 months seems linked to symptoms lasting longer.
So getting onto it quickly matters.
Absolutely. And just to reiterate that definition point, over a third of kids do end up with chronic symptoms lasting more than 8 weeks.
Right.
Peak age for it becoming chronic seems to be around 1 to 4 years old, when those bowel habits are really being established.
And the notes also mention prognosis might be less favorable if the child has other significant issues like psychological disorders, autism, or major family stress.
Yes, those co-occurring factors can make it tougher to manage long term.
Finally, complications. If constipation isn't managed properly, what can go wrong?
Several things listed. Fecal impaction, that painful buildup, chronic constipation, the condition just persisting, megacolon, the colon getting enlarged from chronic stretching that's in severe, long-standing cases,
Yeah.
rectal prolapse from all the straining, anal fissure, those painful tears perpetuating the cycle,
Right.
stool withholding behavior, becoming ingrained due to fear of pain, encoprasis, that overflow soiling, psychological effects, anxiety, frustration, low self-esteem for the child, it can really impact them. And the final crucial message from the material is early recognition and appropriate management diet, fluids, meds are absolutely key to preventing or minimizing all these complications. Early intervention is everything.
Wow, okay. That was a really comprehensive run through, pulling out all those high yield points from the notes on childhood constipation.
Yeah, we've covered a lot. Definitions, causes functional versus organic, presentation, the crucial do's and don'ts of investigation, the step-by-step management plan, prognosis, complications. The big themes are history and exam first, know your red flags, and commit to long-term management.
It really highlights that it's more than just infrequent pooping. There are specific criteria, a need to rule out other causes, and it requires a proper plan, often involving medication and behavior support for quite some time.
Definitely. And maybe a final thought to take away. Think about how complex that interaction is between the physical act of pooping and a child's developing psychology around control, pain, and toilet training. Understanding that mind-body connection is maybe just as important as prescribing the right laxative for long-term success.
That's a great point. Well, we hope this deep dive has given you a solid framework for tackling this topic in your revision. And if you found this useful, don't forget passthemsra.com and freemsra.com have loads more resources to help with your MSRA prep. Definitely worth checking out.
Keep exploring, keep learning.